I think it's probably fair to say that everyone in the audience, or nearly everyone in the audience, has seen our next speaker, Dr. Deborah Birx. She ran many influential programs at the Center for Disease Control, CDC, but then was tapped to serve as the White House Coronavirus Response Coordinator in what, by all measures, was an incredibly difficult job, and yet she persevered, and under circumstances that most of us would have long wilted away from, to serve our country. Those of you who've read Tony Fauci's book, as I have, know that he's got tremendous respect for Dr. Birx, and viewed her as a critical ally in the tough situation that he was trying to navigate as well during the pandemic. Dr. Birx is currently a Bush Institute Senior Fellow and a professor at the Texas Tech University Health Science Center. Dr. Debbie Birx.
So thank you. It's really terrific to be here, to hear the questions. Lucy, thank you for the kind invitation. I don't know where Naomi is. Thank you for keeping us straight, knowing what we're supposed to be doing. So we've been through two very large pandemics over the last 40 years, and in my perspective, we haven't learned from either of them, either the HIV pandemic or the COVID pandemic. We know pandemics are always political. They've always been political. I think we so quickly forgot HIV. Do you remember the mosquitoes, the kissing, the miracle cures, the going to Mexico? Okay, that all went out of our heads. And so it was like the media was shocked that the pandemic, COVID pandemic, caused misinformation. But all pandemics cause misinformation. I've been privileged to work overseas almost my entire life, and Zika, Ebola, all of them had misinformation and miracle cures. Because when people get fearful, they will hold on to anything that will anchor that fear. And so I don't know why we don't learn from these things. I don't know why we don't learn to communicate better with people from these things. But we also had subgroups and actually very competent people who remember, I'm looking in the audience, there are some people that will remember, there are people who said HIV didn't cause AIDS. Very competent scientists who thought it was a fungal infection, held on to that for a long time. So this is not unusual that scientists disagree. It's not unusual that there's misinformation. And despite all of that, between HIV and COVID, we didn't improve our communication with anyone. In fact, I was always impressed that CDC every year published how poor the flu vaccine uptake was in particular pockets in the United States, and we did nothing. We just tracked it. So we've been just watching the data for decades, but not actually doing something about it. So I was privileged to work on HIV first with Dr. Fauci and Dr. Redfield in the early 80s before we knew it was HIV. That was when we used to eat in the lab. When they found out that I was transporting HIV samples and we were looking under the phase microscopes eating our popcorn, all of the HTLV1 people got very upset with me. But we all were negative after we were tested. But what I've learned with HIV is that political will matters tremendously, and I think we saw that with COVID. And the reason political will matters is because policies matters. Because early on, when we just had to talk about these emerging pandemics and these emerging viruses, all you have for countermeasures and day one is communication and policies. That's what you have. Now, we can say, oh, it's great, we're going to have a vaccine in 6 months, but you've got to do something on day one. And I think the way you make policies and political will is data. Because all of us have perceptions. And what data allows us to do sometimes is convince people that those perceptions and assumptions are wrong. It also allows us to learn from highly successful sites. Having I just believe in data. I believe it's the music of science, but I believe it also is the way to unite us and to convince anyone that we have to look at things differently. And I think if we provide transparency there, it will be important. Now, people say all the time, oh, it was very difficult in the White House. Well, it's been difficult to work on HIV for 40 years. I mean, there's a lot of cultural issues. There's a lot of stigma. There's a lot of discrimination. There's no prime minister or president that I've worked with around the globe that is very interested in embracing the LGBT community. I mean, we just have to be honest. But with data, and them having to see where their gaps are in their program and the ongoing transmission, they're willing to actually consider different ways of looking at things and different ways to implement, and then to really work on these structural barriers that we all know happen. So this is what political will looks like. I've kept this slide over the decades. This was done long before Ukraine. This one shows with new infections in Russia and new infections in the Ukraine, very similar epidemic, almost identical clade of HIV infecting the populations, primarily driven by people who inject drugs, small MSM population. One country understood that peers and community outreach and community work was much more effective than coercive and imprisoning actions. And so Ukraine moved to funding local peer communities in past injectors who really worked in the community outside of government to really decrease structural barriers and ensured access to both prevention and treatment. And so they ended up with a very different response. And today, these graphs look very much the same. I tried to pull the new data, but Russia has removed all of its data from AIDS info at the UNAIDS website, so I can't update the slide any longer. But within our work overseas, granular data allowed us to really identify key gaps. Because in the tyranny of averages, of looking at a country, or even looking at a state, or looking at a county, without knowing the granular disaggregation by age and sex, you really lose all specificity and know what you have to be doing. When I took over this program, the PEPFAR program in 2014, we had not aligned our resources with need. And I've learned over the years that no one ever thanks you for giving them more money, but everyone complains when they lose money. And they end up going to Congress and complaining. So that's just the reality of life. So if you want to lead in global health, you have to have a pretty thick skin, because in order to align with equity, you have to constantly be moving money to where the need is, away from people who have solved the problem and no longer need those resources. So we had to really align our HIV program to the burden of disease. And then we created pillars around accountability and transparency. What did this mean? In PEPFAR, which is the President's Emergency Plan for AIDS Release, if you go to pepfar.gov, you can see every site, their viral load suppression, how well we're doing with your taxpayer dollars. This is helpful in the United States, but it's really helpful at the sites, because sites can say, oh, you know what? Their retention of 20 to 30-year-olds is much better than our retention of 20 to 30-year-olds, and they'll reach out and ask, what are you doing? So having data being transparent, which we seem to have a real problem within the federal government, is like we don't think people can understand the nuance of data. I heard that always during COVID. I was like, why are you saying these things in black and white when it's highly nuanced? And they said, well, the American people can't understand nuance. And I said, well, everybody in Africa understands nuance, so I don't know why the American people wouldn't understand nuance, but that is really critically important. So we thought we were doing great with HIV, and then we went in and did community surveys and found out that stipple area is all the people that we had missed off a treatment. And so we weren't diagnosing and treating whole groups. We were doing really well with women because they were tested when they were pregnant. And so we were finding women, getting them on treatment, and then it created this whole sense that there was only transmission and only women had HIV. It took a long time to find the men. I finally had to ask the private sector to come in, and that's another thing. You just have to admit when you're failing. I called up the private sector and said, can you come and help me? I can't get men between about 20 and 45 on treatment until late. They came in, they talked to all the men. And I had been talking to the men too, and they said, we want male nurses and we want different times. And I did all of that stuff. Nothing helped. And then they came in and the private sector talked to them, and they came back and said, well, men only trust one person in their lives. And I was like, wow, I had daughters, so who knew? Their moms. Men believe that their moms are looking out for them. They really don't trust the rest of us for other reasons. So I knew where the moms were. The moms were in churches. So Sunday mornings, I went to churches all over Africa. We spread out. We got all of our partners to take self-tests into churches, give them to their moms, and say to their moms, we want your son to be healthy. If you get them tested, we can get them on medication. They can be virally suppressed and live a normal lifespan. We got 2 million men on treatment in 18 months. So these simple solutions, but you got to find out what the problem is, and then you have to find out what will drive that person to the behavioral change that you need in order for them to thrive. And so that's what we did. And integrating the data, I just wanted to show you what happened with Eswatini over the last 15 years of the work of your taxpayer dollars. This is deaths and new infections, showing that you can tackle a pandemic without a vaccine. So we've dropped new infections by about 75%, deaths by about 90%. This is the number of people on treatment. We're nearly at 100%. And not only are they on treatment, but they're virally suppressed. And so really looking at the impact of your program is key. But that last graph, total population with HIV, that in the long run is what's going to decrease cost. As the population ages into normal life expectancy and you have less and less new infections over the years, there's less and less funding needed. So in controlling the pandemic, we're decreasing the out-year costs. So through that approach and those extensive databases, I was in Africa in January and February of 2020, telling all of the leadership to use the HIV money and the data systems for COVID. And so all of our patients, by and large, stayed on treatment. So we didn't lose people to treatment during COVID, no matter if it was rural or urban. People stayed on treatment because they had a relationship with their providers and with their community, and that same relationship was used for COVID. Now, this goes to show you what happens when you sometimes take the eye off the ball. Over the last few years, you can see the absolute number of people on treatment has plateaued. The number of people actually added to treatment has dramatically decreased, and this is what happens when you don't keep people in care. And so this is really a reflection of losing 20 and 30-year-olds out of the system and out of care and no longer virally suppressed. And so this is a warning sign for the program of how they really need to refocus. So what happened with COVID? So you might ask, why was I in Africa in January saying get rid of for COVID, and in the United States, we were saying we only have 18 cases? In the United States, we have chosen to surveil disease through symptoms in the 21st century. Now that ought to freak everybody in the room out because we diagnose everything else. Can you imagine going into your provider and the provider saying, well, I think your symptoms are consistent with cancer? We would go, what? That's not acceptable. We want to know, where is my cancer? What is its genotype? What is its type? How is it going to be responsive? What kind of treatment I can get? What are the numbers? What am I going to do? No, we're still tracking by symptoms. Our largest syndromic flu and RSV and COVID database are syndromic emergency room visits. Now, I will tell you that people are filing those tests to get reimbursement. So these tests are being done. So in a country that is in the 21st century, we should be tracking viral diseases by test. Because the reason we didn't see COVID is it was a little distorted early on by flu, probably in China. Now that we know the time course, there was clearly widespread COVID in November and December in China. You can't have the number of deaths you had in January without, we know the cycle now. So now that we've lived it for the last 5 years, we know what actually this cycle of COVID is. We know from the first cases and community spread to the 3-week later hospitalization to the 2-week post that mortality. We know it's a 5 to 6 week cycle. So we know if you had deaths in the beginning of January, that you had COVID the end of November. And I'm sure that they saw respiratory disease, it was winter, thought it was flu, because we don't test. So I was hoping that this wake-up call would be that we would go back to testing. But no, I'll show you what we did instead. But when I came into the White House, Bob Redfield handed me this sheet of paper, and he said, "This is our data." And I was like, well, there's a secret database, right? No, this was the data, presumptive confirmed cases. This is it, on an Excel spreadsheet. No testing. Now this is March. This is like March 3rd. I had more data in Africa about viral suppression than the United States had about RSV, flu, and COVID. And so what I did is I called up all my colleagues around the world, including my colleagues in the Global Fund that work in China, and I had them send me all of their data, which they did. And so the reason the United States could talk about COVID was not because of our institutions and our data. It was because of connections to other countries who shared. And we just have to remember that people shared. When they were in the midst of their own crisis, they sent me information. So it was very clear in this cases of China that most of the deaths were in people over 50. Men were slightly higher mortality, same way with South Korea. The thing about South Korea that I found very exciting, of course, they were testing. So they could tell you there was a lot of asymptomatic cases. All of those oranges are asymptomatic cases. So high number of asymptomatic cases on the one side of the ages and high number of deaths in a different group. So you knew right away the virus was spreading asymptomatically. But it took the WHO and CDC until July to admit that the majority of the spread was asymptomatic. When South Korea knew this and had this data in March. They also had I like to triangulate data, so the fact that South Korea and China had almost the same profile of mortality, most of the mortality, again, over 50, and again, linked to the comorbidities. So we were able to come out and talk about the risk related to comorbidities. Italy did the same thing, and they were only a couple weeks ahead of us, and so they were really in deep trouble when they were sending me this data, and they were sending it to me nightly so I could see who was hospitalized, who was dying, and what the case fatality rates were. Again, Italy looked like South Korea, looked like China, across multiple genetic patterns. I felt pretty confident then when we went out in early March to say this is primarily a disease that is going to affect the elderly. But the elderly, and this is where we got into a lot of controversy, the elderly do not live in nursing homes. The elderly often live in multi-generational households across the United States and in communities. So even if you attempted to protect them in the nursing homes, it was never going to be enough because that is not where the elderly live. The elderly live in communities, and 60% of our elderly are providing the primary child care for families so that the family members can work. So when we start putting this data together, and this was what I made for the task force, I think like March 12th, showed them that all of the green is asymptomatic and all of the orange is illness. And you can see with multi-generational households, it was going to be really impossible to protect the vulnerable outside of all of America because of the way people were living together. So we use this data to actually get that 45 days to slow the spread. Again, the federal government could not mandate any of these policies. They all had to be done at the state level. What the 45 days to slow the spread said is to use this time to expand testing, which we did, and really give states a time to catch up and get ahead of this, and so that their hospitals could get ahead of it. We also used that time to get data from everywhere. And so I called up these machines that we were using. It was so great for me because they were RNA machines and what I use for viral loads. So I could call up Hologic and Cepheid and Roche and Abbott and say, can I get your nightly feeds from the hospitals? And so they were sending me in their data feeds from their machines because they all are up in the cloud now. So those data feeds, I can tell you, were quite scary, because the first time I got them, it was 60% of the tests were positive in New York City on almost all hospitals. So that was a very scary thing to think about, how many people in the hospital already had COVID. So we spent a lot of time pulling all these databases together. We started creating reports for every governor. These went out weekly so that people could see their states. Numbers are important, but I find trend lines are much more important. It's what allowed us to see every community, every state, every age group. These went out weekly so that you could see whether your hospital rates were rising across the country. That really helped us move commodities around to the different states that needed them. We got feeds from every single county in the United States, the over 3,000 counties. So at any one time, just happens to be January 5th, the surge that winter started, of course, in North Dakota, the northern Montana, Wyoming, and then spreads out to the coast. And so those states were getting better, and this is how we could really predict county by county who needed what. And then we did a lot around percent change, because I like to know which way the trend lines are going and how steep the slope is. And I think you can see this just shows you test positivity. Now, everybody was getting test and test positivity, all of these. Now imagine if we had this for everything. Imagine if you had county level maps for diabetes, hypertension, RSV, flu. We're capable of doing that today so that communities can know how they're doing compared to other communities. So they can start understanding what's working at the county level, because that's where people live. They don't live in the United States. They live in a county with a school board. And this kind of information could be really helpful to them. Anyway, we created all these maps, all these trend lines, and then they were all taken down. I was hoping, and we did these by populations because we wanted to be able to look into small towns as well as large towns. What I was hoping would happen is, for once, we would have a national health database where immediately you could see where things were, how you were doing, how you personally were doing compared to the people in your county. Imagine being a parent and knowing that RSV was circulating in your county, and the risk of RSV to the elderly. You might get grandma, make sure that she had the RSV vaccine. People will use information if you give it to them. Instead, we took this all down. So all of that national database is now gone. There's remnants of it at the CDC. I'm grateful that they're putting the hospital database back up. That was taken down too, so no one could see it. Now, what went really well during COVID? Well, number one, there was a great partnership with the private sector. And so they were able to get us PPE. We were able to have tests on every single platform in the United States within 6 weeks after we held a meeting with all the CEOs. They went back, they made tests that quickly across all platforms. Not only just the big machines, they had those simple antigen tests available within weeks, and that's what the power of our private sector is. The long-term funding of NIH allowed us, and all of the funding that goes out to academic institutions, to really know how to stabilize a spike protein. That's what made it capable. That was a lot of investment that had gone in from HIV. Telehealth became very valuable. Rapid tests for the moment became really terrific, but now instead of having more, an RSV, an STI, a respiratory disease panel that you could do at home so you didn't have to grab your kids up and get them to urgent care, that you would know, and then you could telehealth and show the picture, and then you could get the right treatment. There's so much we could have done, but a lot of it we have dismantled. I think what the FDA did with emergency use authorization was great. So then what went wrong? Detection failed. I mean, we should all be a little bit freaked out. We spent all of this money for all of these decades saying we were going to prevent illness because it was going to be prevented over there and it wouldn't come here. So all of our detection was out there. None of it was in here, and that failed. We failed to do the behavioral research to understand what would drive people for vaccination. If we had done that with flu, we would have been ready. We poorly communicated about the evidence base. I tell you what has made Americans most angry is this whole 6-foot thing based on droplets. And you wonder why they don't use masks? Well, because we told them all of this stuff about fomites. They were spraying down their Amazon boxes and breathing in the elevator because no one was there, and believed the elevator was safe because they didn't see anybody. There's no ventilation in elevators or bathrooms. If you can smell things, there's not good ventilation. I know most people say look at CO2 monitors, but if you go into a bathroom and it smells, okay, there's virus there. But the people feel betrayed because you told them all this fomite and surfaces and they're washing hands and they're using hand sanitizers, and it really was just breathing. And it took 4 years for WHO to put out aerosolized viruses. 4 years after COVID. So when you start putting the pieces together, you can understand why we have disenfranchised the American people. When the CDC said you don't have to wear a mask anymore if you got vaccinated, that implied that the vaccine was going to protect against infection and transmission. It did not. And so the American people are like, well, you told me, and then 6 weeks later I got infected. The vaccine was never studied to prevent transmission, never. It was voluntary, syndromic. If you have symptoms, come in and we will test you. That was the trial. We did not test people on a regular weekly basis. We only tested people with symptoms. So it was never studied. Not a single phase 3 trial was done about protecting from infection. Yet we implied from the American people that we knew that. And if we look at vaccine hesitancy, it has gone up by several logs because now they believe if we didn't tell the truth about COVID, what are we hiding about childhood vaccine? So where are we? Well, we've had 650,000 deaths in the last 3 years with tools and countermeasures because the group that is still at the highest risk, we're not doing everything we can to prevent infection. Now, I show you this picture from South Africa because it was very clear to me, and it should be very clear to all of you, that there was never going to be herd immunity. And we had this data in December of 2020. That second peak in South Africa was, and I really applaud South Africa for doing great testing. They were great about testing. And almost 50% the people in that second peak had already been infected once. So when there's no natural immunity to protect you from reinfection, okay, we don't usually do better in vaccines. So once we saw this, it was clear that there was not going to be protection from reinfection. And the entire immunization program should have been based on people at risk who were most at risk for severe disease because we know the protection from reinfection was not going to exist and you would not have herd immunity. I'm just going to conclude with one thing I want to say about rural health care, but H5N1, we made exactly the same mistakes, and that's why I'm so worked up about this. We decided to file cows and people by symptoms again. So we didn't test every dairy worker. They could have been done anonymously. If you had gone into a dairy farm and said, here's viral transport media, have your workers test and put them in a pool, and we'll pick them up Friday, and we'll run them and we'll tell you how many pools are positive. They would have done that. We didn't even try. Instead, we went back and did some antibody measurements to show that, probably 15 to 20% of the infections, that 15% of the people were infected, and it was asymptomatic. But we didn't even try. So we're making exactly the same mistakes that we made before, and we're not dealing with long COVID. Now, I just want to say this last thing about, and I'll just take 5 minutes because it's my passion about rural health care. When I went into the tribal nations, and I went to 44 states multiple times while I was in the White House, because that's really where the action was at the state level. And I was meeting with the tribal chairman. There were about 10 tribal chairmen around the table. And they were like, thank you for coming and talking to me about COVID, but we've been dying of diseases of despair for decades, and no one has done anything. Nothing. Their life expectancy, you can see, was always 15 years less than many Americans. Yes, it got worse with COVID, but it was already terrible. And we had this data, and we just ignored this. We politicized COVID on both sides of the aisle. I don't let anyone off the hook. I really blame the media for calling these rural counties Republican counties. Like somehow it's how you voted that determines your state of health. It is not. These Republican counties are rural counties. They're not Republican counties. They actually have Democrats in them. They're not monolithic counties. This was published by Scientific American in December of 2019. We have been tracking that the Republican counties, rural counties, have been stagnated and dying at a 20% higher rate for over a decade. We did nothing. We just watched it. And it's included across young people. This is, again, at the county level. But the CDC put out this recently, showing that these non-core micro populations, small metros, have done persistently worse, whether it's cancer or heart disease or chronic respiratory diseases. And of course, we know there's maternal deserts. So I believe strongly now that I've seen that, and this is why we went to sub-Saharan Africa to change the HIV pandemic, because they had a much higher rate of deaths and destruction than we had in the United States. And it's been going on in the United States, and we're just tracking it. I feel like we're one of those people who just say, if you see something, say something. Publishing a paper on how bad it is in rural America for cancer and heart disease and diabetes is not doing anything to help them. That is not public health. Public health is taking data and acting on it. Public health is going into those counties and figuring out how do you do something. And so that's what we did. We spent the summer in West Texas doing a community-based survey in the town. I'll just finish with this slide. 30% of males have not been to healthcare providers. We're used to seeing that. But 58% of the population had diabetes or prediabetes. This is people over 18. And 22% had diabetes. Most of them had diastolic and systolic hypertension. 50% of them had a BMI over 30, but they had more diabetes than they had BMIs over 30. This is our crisis. This is our crisis of chronic disease. We're letting it happen. It's asymptomatic. But you can do something, and you can change the future of a 25-year-old with a hemoglobin A1C of 6.1. You can do something about it. I'm committed to do something about it, but I really appreciate the time to be with you all. I think we're still failing on prevent, detect, and respond. I appreciate the science that you're doing, but the science only works if you detect. And we are still not in the place of detecting these new diseases. So thank you for your attention. I hate being right before lunch and getting everyone worked up about where we are, but now we can talk about it for an hour. Questions?
So you said something very, you made a very important remark. So you said, you made a distinction between stopping it over there and what's happening over here. But in this case, over there, they actually stopped it because China was fully COVID-free by May 2020, right? And the world was actually doomed to endemic COVID by the US in many ways, because other countries face the dilemma of, actually the country I come from also eliminated pretty much by May 2020. Then we had the worst outcome in the whole world due to it. And the reason was that we faced the choice of, either we sever diplomatic relationship with the US and shut down travel and we live like hermits, or we let it rip. So we let it rip, and a lot of people died. So that's what happened, so.
Yeah, well, if we tested, and I'm not going to get into what China did to control their pandemic. It would never be acceptable in the United States. They controlled their pandemic by locking people in their rooms. Even, I will say, our mobility only went down by 50 or 60%. Europe's went down by 90. I mean, yes, we all did great. And the work that everyone did was extraordinary. But we were much more mobile than any other country was that was battling the pandemic. And that's how we are as Americans. We're a very free-loving spirit. And so we have to find solutions that fit in with the American culture. And so, yes, if you lock the apartment building and you don't let anyone out, you can control COVID.
So actually, the key tool in the Chinese arsenal is the mass testing. Just line up everyone and test them. And,
Mass testing did work, and I really applaud the universities that used that. We kept universities and schools open without any significant spread by just weekly testing, because most of them were asymptomatic. So this quarantining of people for exposure doesn't make any sense, but if you test people, they're willing to say, okay, I understand I have the virus, I shouldn't expose others, and they're willing to take out that 7-day time period. But it has to be based on a test, not on your perception of whether they've been exposed or not, because, yeah, go ahead.
I think it's worse than some states simply don't respond or not respond. I think some states actively do not want to help their people. For example, 10 states in this country, I think it is, I forget the number, it's about 10. I sound like Donald Trump now. 10 states don't have their citizens on Obamacare. They've chosen not to do that. So it's not that they sort of do it or don't do it. Some people don't want to take care of their people.
This became, and I'm just going to say, it's a bit of a myth. I was in all the states. I was in both Democrat-led states and Republican-led states. And I will tell you that Texas, and you probably think they didn't, but Texas had testing and mass mandates. It was based on data. So if there were more than 50 cases in a county, that county went under a mass mandate. Mississippi had a mass mandate. Alabama had a mass mandate. So, we've made, and it was based on data. So, we make these generalities, and we're pushing people to the tails, and the middle's getting smaller. So we can continue like this, or we can be real public health officials and scientists that say we're here for the whole block of people, and we're going to figure out how to pull in the people who may be in a state that has, a different perception about rules and guidance and mandates. And we can spend the time working with people and empowering them with data rather than, so I really believe in education versus mandate now, because I don't think the country is going to listen in the next pandemic and we've got to be honest, we did not tell the truth always about vaccines. We knew that this was not a vaccine protect against infection, but we made that implication. And then people don't trust us. So this is what we are up against. And we can either point fingers, or we can work together to get the data and move the country into a place where we're knowing what we're facing. I really, if we would just test, or we would get the feeds of testing machines at the national level, because Abbott and Roche all have them, you would be able to go into your community and speak from a point of data and educate from the point of data, and you wouldn't have to mandate, because people don't want to kill their grandparents. They truly don't. If they have the information, they will do the right thing. I believe in human nature, doing the right thing. I know you think that may be Pollyannish, but I've seen it all over the world. And I know what we're doing right now in this country, and we're not going to be able to implement public health if we keep saying you did this and they did that and it's not good, and they got elected. I'm just saying, they got elected. They're elected in their states, they're elected as presidents. We need to figure out how to make data accessible and help educate the American people so that they can be empowered and make decisions that's best for them and their family. I trust them to do that.
Thank you so much. To your point about data, first of all, I couldn't really get good data from the government, so I used the Johns Hopkins site, and it stopped cold on March the 10th, 2023. So I backed up and I used the Worldometer site, and it stopped tracking
Yep,
data
April.
on April 13th
Yeah.
of this year. And also, most of the testing is done with rapid tests, of which no data is collected. How do we go back and get data?
Because you can take the trends from the urgent care, and then you'll be able to understand whether COVID cases, RSV cases, and flu cases are going up.
But I couldn't even find data on urgent care or hospitalizations or death.
And you know that they're submitting those for payment. So, I mean, we have EMRs. You got to code this stuff. We could make codes 24-hour reportable like you do for clinical trials. I mean, people will do the right thing. People told me that the reason we didn't have a good hospital data and we were modeling everything that was in hospitals, and I was like, I don't need a model. I need to know whether the hospital has 6 patients or 10 patients because I have to get them remdesivir. And I don't have enough remdesivir for 10 patients if they only have 6. So I want that remdesivir to go to the right place. And so I asked hospitals to send me their nightly data. And everybody said they wouldn't. 6,000 hospitals, we had 93% reporting by that first week. People want to help. If they know the reason you want it, they will help you. We don't ask. We just assume they're not going to help us. Everybody I asked helped me, and they've been helping me ever since. So I think if you ask, you get. If you don't ask and you decide that they're in that corner or this corner, you're not going to get. And I think we have a way to get that data today, and we can start modeling. Yes, there's rapid tests out there, but we have enough data streams to know whether the slope is going up and how fast it's going up, because that predicts how many people are going to be hospitalized. You can get that from the data feeds we have today if you use them.
I appreciate the focus and the reminding everyone that not to treat everyone in bad faith. That most people actually do want to help. My question is for younger scientists in training, and also for older scientists in training. What might one do to help increase these interactions with policymakers, and also, if all we can do is do the science and find the things.
Go to the school boards.
Yeah.
Go to school boards and ask if you can talk in the different schools, because kids are really smart, and explain to them how vaccines work. Because right now everybody's confused about, okay, if I get measles, I was protected for decades. Okay, that's why the measles shot protects you for decades. I mean, we just have to go back to fundamentals. All of you can do that. You can be a voice in the churches, in the schools, with the county commissioners. Hopefully you'll do outreach into Central California, because they also need care and the information. And I think you're a force multiplier. And I think if we work with 15, 16, and 17-year-olds, they'll take that information back to their parents. They want their parents to be healthy. They want their grandparents to be healthy. So if you provided information like RSV is in this community, help us get your grandparents immunized that haven't been immunized for RSV, they would have helped. I don't know, you know how to use all that YouTube stuff, and that helps too, because they are watching you on those things that we don't know how to utilize effectively.
You were talking relating to Native American and treatment for that. So how do you think we can, in terms of people of color who are at much higher risk of these things, how do you think we can deal with that kind of disparity and actually get those people the help that is just as they need just as much?
Well, we've allowed, and I think you can all see it. If you live in an urban area, there's an urgent care on every corner. If you live in rural America, there may be a clinic there, but it's only open 9 to 5, and everybody is working 9 to 5. So we have to adjust to communities' needs rather than forcing communities to adjust to our convenience. And that's how you really start to build trust, is when you go into communities and you actually listen to what their availability is, what they really need, how could we facilitate it, and then act on it. Because a lot of them have spent time giving us this information, and then we didn't act on it, and that just breaks trust.
I just wanted to make a comment, and I think this is a good audience for it, about the communication issue. Because scientists have a lot of platforms, those sort of amplified messages during the pandemic. I was the infectious disease editor at Nature Medicine during that 4-year period. And we made a lot of mistakes. Scientists made a lot of mistakes because we did think erroneously that the vaccine would actually be neutralizing. We weren't communicating as scientists that, in fact, the important issue was prevention of severe disease. Scientists did not believe that people were getting infected a second time, 4 weeks later, 6 weeks later. So we also made mistakes, and I think that's something to sort of be ready to correct using your online platforms as scientists. Here's now the data. We were wrong. We need to think about these things. And I think as a scientific community, we also
And that would
need to
go
do
a
better.
long way, because right now they think we're hiding it. And in a way we are. And I think if we want to be ready for the next pandemic, a lot of it's technology and science and what you're doing, but a lot of it is just talking to people one-on-one and group by group, talk about the science that you're doing, and to take that in the same time and say, this is why we made the mistake. But this is how we're correcting it. Because I think we are, but we're just doing it silently because we're a little embarrassed.
Great. Thank you very much, Dr. Birx. We will start again promptly at 1:30.